My name is Tony Brantley, and I am a program coordinator with the Community Health and Wellness Team at Suburban Hospital located in Bethesda, Maryland. We're thrilled to have you with us today for this important discussion. Throughout the presentation, we encourage you to submit any questions for our guest speaker using the Q&A box or the chat at the bottom of your screen. At the conclusion of the webinar, a short evaluation will appear. We will greatly appreciate your honest feedback as it helps us improve future programming. Please note that today's webinar will be recorded. The slideshow from this presentation will also be shared with all community members who registered for this program. Again, thank you all for being here. It's now my pleasure and honor to introduce our guest speaker. Deborah Horwitz has been a practicing dermatology physician assistant, also known as a PA, since 2014. Deborah specializes in medical dermatology for adults and pediatric patients. She is nationally certified by the National Commission on Certification of Physician Assistants, a member of the American Academy of Physician Assistants, and serves as the chair of the Government Affairs and Advocacy Committee for the Society of Dermatology Physician Assistants. She was an assistant professor at the University of Tennessee's PA program and directed the dermatology course. She graduated with a master's degree from Baylor College of Medicine's PA program in 2010. Prior to becoming a PA, Deborah worked in healthcare public relations and lobbying, as well as working on Capitol Hill, and she maintains an interest in healthcare policies and advocacy. She received a bachelor's degree in political communications from American University in Washington, D.C. in 2005. Deborah is originally from Austin, Texas, but excited to again call Washington, D.C. home. Without further ado, I'm honored to present Ms. Deborah Horwitz.
Hi, everyone. Hi, everyone. I'm so happy and thrilled to be with you today and share some, tips for skincare and healthy skin aging. Skin is obviously my passion, and I really enjoy doing what I do and seeing patients and helping them with all different types of skin disorders and things that are on their skin and different types of diseases or manifestations. And so my goal is here to keep it pretty simple today and cover a lot of topics that would be salient to you and of interest to you and common things that people tend to have a lot of questions about. And my goal is that you are able to learn something from this talk today and be able to take something away. All right. So you already heard a little bit about me. So again, I'm really excited to be back in DC. I am a native Texan, but my parents are originally from the DC area, and so it's sort of like a second home to me. And I am so happy being here at Sibley and being part of the amazing institution that is Johns Hopkins. So happy to be here and share with you today. And if you have any other questions about me, happy to take those as well. All right, so what are we going to get into today? Oh, sorry, and I do have two things that I want to say before we get started. One is in terms of these slides being shared, most of my pictures and things are basically publicly available on the internet, as well as some of them being from common dermatology textbooks like Fitzpatrick's book of dermatological diseases. So anyway, I don't have references on every single picture. And then in terms of the content of this lecture, it's from me and, I am the creator of this content, but I'm happy to share it with you today. In terms of the photos, I like to, obviously dermatology is a very visual field, so I am going to show you all a lot of pictures sort of in the second half of my talk today. And I tried to make sure the pictures weren't too graphic, but obviously my threshold of graphic might be different than you. But I think that these pictures are really important to kind of help you see, especially in terms of signs of skin cancer. It is really good to see a lot of different type of examples of different types of things that grow on the skin so that you can start having an idea of what you might be looking for at home as well. So just a little disclaimer on those two things. Okay, so what are we going to talk about today? So definitely we want to talk about common skin concerns, things that, everyone wonders about. Patients come and ask me every day. And so I definitely want to try to address a small number of those very common concerns. Then we're going to move into my daily skincare recommendations, which helps with, dry skincare, some anti-aging discussion, as well as most importantly, sun protection. So that's going to be a third part of my talk, where we'll talk about specific types of sun protection, what the difference is between a chemical sunscreen, a physical sunscreen, what kind of sunscreen should you use, and how do they work, and how do you make the best choice. And then that will lead us into skin cancer. And so we will talk about different types of lesions that occur on the body, and what you can look for, how different things look, how one skin cancer looks, and how it looks different than another type of skin cancer, and signs of concern, signs to definitely maybe schedule an appointment with a provider, with a dermatologist, to see what might be going on. Then I definitely want to let you know about some over-the-counter options that are actually quite good, and we would highly recommend things that aren't too expensive, things that you don't even need a prescription for. So I definitely want to give you some of your drugstore go-to items. Old dog, new tricks. That is going to be the end portion of my lecture, where I'm going to go through a few common chronic skin diseases that maybe you have, or maybe you've known somebody that's had something like eczema, psoriasis, and how actually we have a lot of new treatments in dermatology that are new. And so maybe you've been told for a long time that there's not much that can be done, and maybe that answer is changing. So I want to give you all some new information about what's available. And then finally, when to seek medical attention, when something on your skin is definitely something that needs to be evaluated by a professional, and when maybe certain skin diseases might need more treatment or a different treatment. So that's what we're going to talk about today. All right. So, one of the most common things that happens as we get older, as our skin ages, is our skin gets dry. It's a natural process, and it's mostly due to sun damage over your lifetime, which makes your skin more dry, as well as loss of moisture, loss of collagen and elastin. And so all those things start to make our skin more susceptible to dryness. And then that dryness then makes it really itchy. So I think we all can kind of relate to, or maybe some of us can relate to, this back being, red and itchy. Really, like upper back is quite common. And then that back scratcher, well, we don't recommend using back scratchers, but certainly it definitely paints the picture of what we're talking about. So let's talk about dry skin and what my general recommendations are for dry, itchy skin. So one of the first things I ask my patients when they're complaining about dry, itchy skin, and I'm not seeing anything on the skin that's actually of concern or looking like a disease, I ask them, what type of soap do you use? And commonly, people from some older generations, they've been using antibacterial soap for a long time. They may not even be aware it's antibacterial soap. So we're talking about Ivory or Irish Spring, and those are a no. The whole reason that antibacterial soaps work is because, the whole reason that antibacterial soaps work for bacteria is that the detergent part of the soap is actually breaking down the cell membrane of bacteria. Well, guess what also has cell membranes? Our skin. And so it's also quite drying and irritating to our skin. Most people don't need to use an antibacterial soap. Most people, we recommend using something like Dove sensitive soap. So the only time that I recommend using an antibacterial soap is perhaps maybe in the underarms, under the breast, or in the groin, places that do tend to maybe get a little bit more bacteria buildup. But I actually don't want you to use soap anywhere else on your body unless you're really dirty or really sweaty. And that does not happen every day or every time you wash. So I really want people to concentrate on just using soap just in those places, underarms, under breasts, and groin. And then, there's going to be soap that drips down other places, but you don't need to take the bar of soap and rub it across your skin because really soap is ultimately drying. So I want you to avoid dyes and perfumes in your soap that also dries out the skin. And the sad thing is, I do need people to discontinue long, hot showers or baths. I know that's especially hard in the winter, but tepid water, less hot water, and less frequent bathing is going to be best for dry skin. So even though it's sort of counterintuitive, really just doing some of these things are going to make a big difference to how dry your skin is without me even having to give you an ointment or a topical steroid or something like that. In terms, the next question I ask is, what kind of laundry detergent do you use? So we recommend using free and clear detergent. So all free and clear actually did a study and they compared all of the free and clear detergents. And actually, Tide Free and Clear ended up being worse for skin, and all Free and Clear ended up being best for skin. And so we do recommend the Free and Clear detergents, but we actually recommend specifically the all or the off brand all detergent. And then we want to make sure that we're avoiding fabric softeners, and we want to make sure that we're avoiding dryer sheets. So all of those things together can actually make a big difference, and they're common everyday things. And sometimes they're completely new to folks, and they wouldn't have even thought that these sort of little day-to-day things matter. And so I've had a lot of success with sort of this education, and the folks will come back and they'll say, hey, actually, that soap, it was the soap that I used, and now I'm using Dove or some other gentle soap, and now I'm not having as dry, itchy skin. So that's what we're going for there. The fountain of youth, everyone's question as we age. And one of our common questions in dermatology, I think it's really cool that I work in a specialty where I can see the organ that I'm working on, whereas in other specialties, we have to like draw labs and do ultrasounds and do CTs to see what's going on. So I actually get to see the organ that I'm working with and see the results. But of course, everyone also can be very concerned about how their skin ages. So let's talk about that a little bit. So what do dermatologists and dermatology PAs generally recommend for your daily skincare routine? This is a very common question. So in the AM, in the morning, you're going to want to use a gentle wash. We're talking about CeraVe. This is a foaming bar. Vanicream is another great option, and Cetaphil. So I'm just throwing out a few brand names. Again, these are all over the counter brands that are not too expensive and that can get picked up. So we're talking about a gentle wash, not anything with any medicine, not anything with any antibacterial properties to it. And then we're talking about, after that, using a gentle moisturizer, some of those similar brands, or you could do a hyaluronic acid. Hyaluronic acid is basically a naturally occurring substance that lubricates our joints, but any hyaluronic acid that you're buying to put on your face, that's going to be a sort of synthetic hyaluronic acid, and it helps sort of retain moisture in your skin as opposed to like a moisturizer sort of keeping moisturizer in your skin. A hyaluronic acid is actually going to bring more moisture to the skin and kind of ideally plump things a little bit more. So hyaluronic acid is a good ingredient to look for. Then you may or may not add makeup over that. And then you're going to always, every day, even on cloudy days, even in the winter, it would be great to use a daily SPF. So that SPF could be a moisturizer with SPF, and there's a lot of brands. Those same ones I just mentioned, La Roche-Posay is another good one, and they have an SPF built in. So when the makeup companies first started making a moisturizer with SPF, they actually were normally 15. So I want everyone to go home and check what their moisturizers are, what SPF is in there. 15, we found with studies, actually doesn't do anything. So it needs to be a 30. And then in darker skin, again, it's a little bit counterintuitive, but the darker the skin, the higher the SPF. So we recommend in brown or black skin, we recommend an SPF of 50. So you're going to wear that every day. Now, at this point, you've probably accumulated a lot of sun damage over your lifetime. But starting today, it actually does matter because you still have a long way to go and you're getting cumulative sun damage every day. Let's say most people say, well, I work at my home or I don't go out very much. Well, I'm sure you're sometimes driving a car. I'm sure you're sometimes walking across a parking lot. And again, all that sun exposure does add up over your lifetime. And the more cumulative sun damage you have over your lifetime increases the signs of skin aging, and it also increases your risk for skin cancer. So, of course, a dermatology talk would not be complete without really making sure that everyone understands the benefits of sunscreen. And again, we're going to talk about sunscreen a little bit more in a minute. What happens in the evening? You're going to want to do another gentle wash, or even just take a washcloth and just very lightly, not scrub rub, very lightly sort of take the day off your face. Then you want to use maybe a thicker moisturizer, something that's a cream. A cream is thicker than a lotion. So something thicker at nighttime, even a Vaseline, Aquaphor, great thick moisturizers. And then again, you could do a hyaluronic acid instead of a moisturizer, either way, or a moisturizer that has hyaluronic acid in it. And then we do often recommend a retinol or a retinoid. So a retinol is an over-the-counter topical vitamin A. All retinoids are topical vitamin A. A retinoid is a prescription strength vitamin A. And so that does help with fine lines and wrinkles. And that is applied only at nighttime because it makes you sensitive to the sun. Then after that, eye creams, there's very little evidence that most eye creams are going to do much. Again, moisturizing overall is good. Keeping our skin more on the oily, on the moisturized side actually does prevent more wrinkling. But as we'll see, I think in my next slide, really, crow's feet and things and dark circles. Crow's feet, we can address. Dark circles and sort of bulging of the under eye, those are very difficult to correct topically, almost impossible to correct topically, if I'm going to be honest with you. So don't really recommend eye creams in general because most of the time they don't really do much. What I'm not going to recommend is toner. Basically, that's another way of drying out your skin. It tends to be a little bit alcohol based. And so I don't want you to dry out your skin. Exfoliating, man, the beauty industry really wants to sell everyone on exfoliating and brushes and things like that. No, we want to keep the skin intact. Our skin is a barrier. It keeps the outside world out and it keeps our body inside our body. It is a skin barrier. And it's super important to maintain our skin barrier. Otherwise, we become prone to skin diseases like eczema and rosacea and other things that come from a disrupted skin barrier. Masks also don't necessarily need to do a mask. I feel like a lot of the masks that they talk about are pretty gimmicky. And again, you're getting your cleansing from your regular cleanser. You don't need to exfoliate. You really shouldn't be doing like a lot of acid things without the supervision, of a provider. So I don't really think you need any masks either. Simple is better. I am a simple kind of gal, and I like to recommend simple routines for people. We don't have to throw the kitchen sink at it, and we don't need to buy every product that we see. All right, so wrinkles. So natural part of aging. We're very lucky if we get to achieve wrinkles. But of course, they can be a cosmetic concern to people. I primarily practice medical dermatology, but of course, I have an understanding and can do some cosmetic consultations. And so this is just a very, overview of some major options in terms of cosmetic dermatology. So, for fine lines, as I was speaking about just a minute ago, we have our retinoids. So, the way that retinoids work is they help peel the top layer of skin. So, retinoids are a little bit irritating and a little bit drying. That's how they work. So, anytime you're prescribed a retinoid, you want to go slow. You want to only apply 1 or 2 nights a week and not in a row, and then maybe work up to 3 nights a week, and then maybe work up to every other night, and then maybe work up to every night. If you can never get to every night, that's okay. I've never been able to get to every night on a retinoid. So retinoids work by lifting up that top layer of skin, and by that they then are able. It makes the lines not feel so deep set. So if you're lifting up those top layers of skin, there's not extra skin that's adding to that look of them being deeper. So this kind of works well in sort of that crow's feet area and a little bit on the forehead as well, as long as those aren't super deep set. And then some chemical peels. There are dermatology offices that do in-office chemical peels. There are estheticians that are quite skilled and can do a nice chemical peel, and those can help as well a little bit with some fine lines and wrinkles. For deeper lines, there really is going to be no cream, no topical that's really going to affect those deeper lines. So we're really talking about neurotoxins, which means Botox or Dysport or Xeomin, which are our most common neurotoxin. And so those are primarily used in the forehead. That's what they're FDA approved for: forehead, glabella, is our 11s, our crow's feet, and so that's the way that you're going to get your deeper set wrinkles to really sort of soften out. And it does take a few treatments because that muscle has been being used your whole life, and you're really showing how the muscle creases. It's just the natural creasing of the muscle underneath the skin over years. And so it takes just like a newspaper. If you have a newspaper that's been folded up many times and then you unfold it, it's going to take, a couple of weeks or a couple of months for that newspaper to not want to stay wrinkled. So the way that a neurotoxin work is that it is a muscle toxin. And so it does create a toxin that then disables the muscle from being able to move in the way that has created those lines. And it's temporary. It lasts about 3 months. So you will have to continue getting treatments if you do it more often, you only have to do treatments about every 5 or 6 months. If you just do it from time to time, it's probably going to only last 3 months. Then there is filler. Again, this is usually a hyaluronic acid filler. And so that is a syringe that is actually injected into certain parts of the skin, typically the cheeks, to fill out the cheek. If the cheeks are filled out more, then that actually lifts. And then you have less of these sort of marionette and nasolabial fold lines. So that's one way of treating this. Filler can be done underneath the eye. Filler can be done in the temples. And so again, you're kind of like playing with adding more volume because you lose volume as you age. So we're playing with putting in that extra volume so you can kind of rebalance, get better symmetry, and then, add back in kind of what you're going to naturally lose over your lifetime. Then we have resurfacing lasers. These are deep resurfacing lasers. So we're talking about our fractionated, ablative. Fraxel is a brand of laser. And so these are very deep resurfacing lasers, and they can go deep into our subcutaneous layer. And then that helps sort of like microscopically damage the skin cells. And then that prompts our body to then start making new collagen, new elastin. So that's the way that a laser works. Prevention, again, is going to be neurotoxin. So if you don't have deep-seated wrinkles yet and you're worried about it, then definitely Botox or another neurotoxin is a good way of preventing them. Skin laxity and volume loss. Again, as I was alluding to when I was talking about the filler, you start losing fat and volume here. You can lose it in around your temples, and then skin laxity as well is often seen in the neck. And so that is going to be filler. So injecting something in to like sort of re-plump it out, or resurfacing lasers. Sometimes microneedling, which is a smaller specific type of laser where, again, they're sort of doing some microscopic damage, but more at the epidermal level. So we have 3 layers of skin. We have the epidermis at the very top, which is what you can see. And then we have the dermis right below that. And then we have the subcutaneous tissue. So the microneedling is where they're making microscopic holes very specifically in the upper layers of skin. And then that microscopic damage then again elicits the body's natural skin rejuvenation process. And then your skin can benefit from more elastin being brought to that part of the skin, more collagen being brought to that part of the skin. Okay. I'm happy to take any of your questions. So I know there were probably lots of questions about different areas that I'm talking about. Okay, so in terms of sunscreen, super important topic. I know there's a lot of back and forth, and sometimes people get confused, and sometimes people are worried about using sunscreen, and they're worried that there's chemicals, and they're worried about it causes cancer or skin cancer. And so, just the short and simple is that any sunscreen is better than no sunscreen. Even starting today, after all these years, it is going to be helping you over the long term and helping you prevent your skin cells from increased damage, and then increased damage leads to DNA damage, and then DNA damage leads to abnormal replication, and then abnormal replication leads to cancer, skin cancer. So we want to prevent that as much as we can. So there are 2 types of sunscreen. There's physical sunscreen and there's chemical sunscreen. So physical sunscreen is only 2 ingredients. If you look at a label and there are more than 2 ingredients, then it's not physical sunscreen. I'm going to talk about that on my next slide in a little bit more detail to give you an idea of what I'm talking about. So zinc oxide, so good old zinc oxide, which is white, and titanium dioxide, which is also white. So it's thick and it literally repels the sun, bounces right off. So it cannot penetrate your skin at all, bounces right off like as if you're wearing clothing, is not absorbed. So types of physical sunscreens that I like to recommend are Blue Lizard is a good brand out of Australia. Trader Joe's zinc oxide. They have a spray version, and then La Roche-Posay also has a mineral sunscreen. So those are some good brands. And then in terms of chemical sunscreen, again, chemical sunscreen is not bad. The FDA has done numerous tests on chemical sunscreen. They are absorbed because they have to be absorbed to work. So I don't know if you can see like my pointer, and I want to make sure that you can see my slide. But basically on this chemical sunscreen side, the UVA and the UVB do penetrate to the epidermis and dermis level. And then what chemical sunscreen does is there is a there is a chemical absorption and dissipation of those rays so that there's not damage done to the skin cells. And so the sunscreen has to be absorbed, and then it has to be on for 20 minutes before it will work. And so there is some amount of absorption. So the FDA has done several trials over, many, many years over and over again. And generally, there is a low enough absorption where it meets the EPA and FDA criteria for what is allowed to be absorbed. But as you can see, these are chemical names, and so they are chemicals. Actually, interestingly enough, there was a recent the safe sunscreen standards. It was House Resolution 3686 was passed in November 2025, and it's actually the first sunscreen related bill in a very long time, where it's going to help to speed up approval of new types of sunscreens. There's other sunscreen ingredients that have been used for a long time in other countries, in Europe and Japan, Asia. And so we haven't updated our sunscreen standards in a very long time. And so this is actually a really good step to increase access to different types of sunscreens that are still safe and effective. Broadband, UVA, UVB. So whatever sunscreen you pick, you want to pick something that is broadband. So UVA is our deep rays. As you can see from this chart, it goes all the way to the dermis. And so that's the rays that cause wrinkling and spots and give us tans. Whereas our UVB is just goes to the epidermis. And so there's two types of rays. And so you want to make sure that it's broadband UVA, UVB. And so it's that ultra sheer Neutrogena is a chemical sunscreen. And Neutrogena was the first one to, or at least since I've been practicing, to really tout this broadband. And so now that's become the standard. Everything's broadband, but you definitely kind of want to make sure that it still says broadband. But so that's a good example of a chemical sunscreen that I recommend, anything in the Neutrogena family. Brands that I don't tend to recommend: Hawaiian Tropic, Copper Tone, just not, I mean, they're not bad. Again, any sunscreen is going to be better than nothing. But let me go to the next slide. There are some sunscreens that kind of try to trick you. If you really do want a mineral sunscreen, that used to be a word where you looked for a label and you saw mineral sunscreen. Well, hey, guess what? I said a few minutes ago that mineral physical sunscreens should only have two ingredients. This one has 1, 2, 3. It has zinc oxide, so that's one of our physical sunscreen ingredients. But then it also has octisalate and octocrylene, and those are chemicals. So I actually had a really hard time finding this picture on the internet because, and so maybe they're not doing this as much anymore. But I've personally been to the store, found a mineral sunscreen that said mineral sunscreen, bought it without looking at the back, and then realized once I got home that they had tricked me and that it actually wasn't a pure physical sunscreen. Again, I had trouble finding this picture, and so maybe they're not doing that as much anymore, but just something to keep in mind if you are really trying to just have a physical sunscreen. All right, so what's on my skin? One of my main jobs is I do skin checks every day. And so that's the question: what's on my skin? So moles. So most people, human condition, have what we call in dermatology melanocytic nevi. These are benign moles. So they have a normal natural history in our bodies. So usually they appear when we're young, within the first decade of life, and they are flat, they're small, they're brown. And then as we get older, in the second and third decades, even fourth decades, they can grow sort of in size, and then they can also raise. And so often people are like, oh, I'm concerned this mole is now raised. Well, it's actually part of its natural lifespan. And so we call that a compound nevus, meaning it kind of sits on top of the surface a little bit, as opposed to a flat nevus is a junctional mole or nevus. Then actually, interestingly, moles might darken, especially in pregnancy. That's a time when there's a lot of pigmentation darkening. And then in later decades, in the seventh and eighth decades, moles might even lighten. So there really is sort of a natural lifespan to moles. And so at every stage, They should be well demarcated, nice and round and regular. They should be symmetric. They should be uniform in color, and they should be like regularly round or regularly flat. Okay, so these are some examples. So now we're getting into the pictures, okay? All right. So these are some pictures of all benign moles, okay? So nothing here is melanoma. So there are some dark moles, there are some lighter brown moles, there are some tan ones. There's one here on the face. That's a special kind of mole called an intradermal nevus, tend to be on the face. This one in the corner here, again, I'm not 100% sure you can see my pointer, but this one in the corner has the dark in the middle, even though that's not uniform in color, which I just said is one of my criteria. We call that a fried egg nevus. It looks like a fried egg. So that is also another normal type of mole. And here I have my ruler here. That shows that everything is, we want things to be smaller than the size of a pencil eraser. So we measure things in millimeters and centimeters here in dermatology. So what about other brown spots? Often people think, come in and think, oh, what about this mole? What about this mole? They actually may not even be moles. So freckles or epiletes, those are, kind of what you remember seeing in kids, where they darken with sun exposure and then they actually lighten with cessation of sun. Whereas solar lentigos or lentiginous are these, more related age-related sun-induced spots. Sometimes they're called liver spots, sometimes they're called age spots. They're really sunspots. And so they're caused by cumulative damage from the sun. And the reason why I said age spots is they tend to occur, in your fourth and fifth decade, because then at that point you've had enough sun damage for your pigment to then start showing that sun damage. So those are lentiginous or freckles. Or our type of freckles that we deal with in dermatology that aren't for kids. And then again, they don't fade with sun cessation. And we actually can treat those cosmetically if they are cosmetically bothersome. So we can freeze them. Most typically, we can also apply some bleaching creams to them. We can do lasers or peels on them. I typically just freeze them in clinic and they get scabby, crusty, and then they peel off. And then you have regular skin that's light underneath. All right, what about seborrheic keratoses, SKs? This is so common and people often mistake these for melanoma and they're very distressed and worried about them. And luckily, they're just benign. I call them a normal human growth, and you get them more as you get older. And I tell my patients you can thank your parents and your grandparents for them because they're genetic. So they are a normal human growth, but the more you have relates to your genetics. So they are definitely all different colors, but tend to be a darker brown. They tend to be kind of stuck on. And so again, that raised sort of feeling makes people a little bit nervous. They can be big too. They can be 3 to 20 millimeters. They can be even bigger than that. So they can worry people because they can be big. They tend to have sort of this stuck on appearance. So that can be something that you can think of at home when you're like, oh, what is this? And like if it seems like you could almost, like pick it off, then that's probably a seborrheic keratosis because that's how they grow. They really like the trunk, they like under the breast, they like the hairline and the temple, they like the back. So they're kind of bothersome for itching because actually they can be quite itchy. And so we freeze them often in clinic if they're making people itchy. And so that's that cryotherapy treatment that I have listed. So here's some pictures. So this is a seborrheic keratosis, not a melanoma. This is a seborrheic keratosis, not a melanoma. This is a seborrheic keratosis. As you can see, it's sort of more on the flesh-colored side. This is a keratosis. This is a keratosis. That's what a lot of keratoses on the back look like. That's what a lot of keratoses on the temple look like. And so as you can see, this is also a reassuring sign. You're not going to have a bunch of melanomas. You're going to have benign growths like that. This is also a type of seborrheic keratosis that's more common on skin of color. So it's called dermatosis papulosis nigra, or it's a type of seborrheic keratosis. All right, so let's talk about, we're going to move into sort of the skin cancer portion of the lecture now. Let's talk about signs of skin cancer and the A, B, C, D, E's and U of melanoma. So A stands for asymmetry. If you were to fold it in half, it wouldn't look the same. So a round mole, if you fold it in half, it looks the same. Um, Something that's more of concern, it might be round on one side and squiggly wiggly on the other side. Border, again, you're looking for a nice round, regular circle border, whereas squiggly wiggly or scalloped would be an irregular border color. Again, someone could have naturally very, very dark moles. If all of their moles are very dark, then we're looking for something that's different than that, or we're looking for more than one color in the mole. We're looking for, we call it variegation, meaning there's like a little bit of red and a little bit of pink and a little bit of brown and a little bit of black. Like that's not a good sign. So, and then D is for diameter. We're looking for smaller than the size of a pencil eraser. Something that's, again, seborrheic keratoses are way bigger than a pencil eraser. So that's why we like to figure out whether it's a keratosis or a mole. And something that started as less than the size of a pencil eraser and then grows, that would sort of be a sign of evolving, E for evolving. And so something that gets bigger or something that changes color. And I'll show you some examples of that. So again, we have asymmetry. It's sort of like a normal mole, but then we sort of have this smudged area for asymmetry. Border irregularity, not a circle, very much a squiggle. Color, there's black, there's gray, there's pink, there's light brown. Diameter bigger than a pencil eraser, and then you can see here evolving. U is for the ugly duckling sign. Ugly duckling sign means, let me go back to my patient who had a lot of really dark black moles, and all of his or her moles look exactly the same. I'm looking for a mole that looks quite different, and that would be the ugly duckling sign. So I'm going to pick the one that actually looks different than the other ones. So some more pictures of just sort of like benign versus worrisome for malignant. I'll pause there for just a second because I know there's a lot on that slide. Okay, so now we're going to start looking at some pictures of signs of skin cancer and what different types of skin cancer look like. There are two main types of skin cells. There's basal cells, which are in the basal layer of our skin, which is the lower part of the epidermis, and then there's squamous cells, which are actually all of our skin cells, and so that's where those two names of our skin cancers come from: basal cell carcinoma and squamous cell carcinoma. And then melanoma comes from our melanocytes, which are our pigment making cells, which is why melanoma tends to be of a brown color or a darker color. Okay, so we'll start with precancers, which are called actinic keratoses. These are small patches. They occur on sun-exposed areas because they're due to sun damage. They're typically kind of scaly, almost sandpapery. I can feel them better than I can see them sometimes. And sometimes patients will say, actually, it kind of feels a little bit sensitive to me. When you touch it, it almost feels like maybe a little sticker or something, a little pinprick is in there if you rub over it. The reason why we call them precancers is because 1 in 10,000 will progress to a squamous cell carcinoma. So pretty low, but the more that you have, the higher the percentage chance. Treatment, we can actually treat them really, really easily, and we treat them with liquid nitrogen, which is the cold freeze spray. We can also do what we call field treatment, where we treat larger areas like forehead, face, scalp, chest, arms, and we can put a topical medicine on there that actually goes and seeks from within the skin, absorbing, and can target abnormally dividing skin cells, and then it will only kill, due to inflammation, those skin cells, and it won't harm the rest of your skin because it's only going to target abnormally dividing cells. There's also photodynamic therapy, also known as blue light therapy, which you may have heard of. This is an in-office treatment where we apply a medication, a topical medication, usually to the face or anywhere that there are precancers, and then you're hit with a certain type of light, this blue light, and then you have sort of like this field treatment all done within one day, as opposed to applying a cream for multiple days or weeks at a time. But it's not available in all offices. We don't have it here at Sibley. I actually don't know who has one these days. Um, and then in terms of freezing, they will get scabby, crusty, and then over 10 to 14 days, they will start to peel off and then be smooth. So here's some more pictures of AKs, or actinic keratoses. There's quite a lot on the scalp. Sometimes it seems like it's dandruff, but it's actually these precancers, actinic keratoses. Sometimes I treat for dandruff and then I see what's left. They're usually on the face, there's some on the arm, and so a few different spots like that. Okay, so then we have our basal cell carcinoma. This is our most common type of skin cancer. Basal cell carcinoma is very treatable. It is highly curable. It is very rarely spreading. So this is a very good cancer to get, if you will, and it is very easy to treat. So typical basal cell carcinoma is going to be a shiny pink pimple-like papule. It tends to look like it has veins over the top of it. Sometimes it can kind of ulcerate in the middle, and that's after it's had a little bit more time to evolve. And so you can see in the bottom picture, there's kind of like a crater. So again, hopefully kind of seeing this pink compared to the flesh color of the skin, you can tell that that's a different type of pink. Also, most people in their later decades should not be getting pimples. Okay, there's definitely occasionally, you get a pimple from time to time, but anything on the skin should heal in 6 weeks. So if a pimple type thing has lasted for more than 6 weeks, then you need to get it looked at. Okay, so what are our risk factors for basal cell? So fairer skin types that burn easily, severe sun damage over your lifetime. So you did a lot of fishing, you grew up on a farm, you grew up on a beach, you grew up in the sun belt, you didn't wear sunscreen, all of those things. Male gender tends to get more basal cells, age over 60, and then immunosuppression, people who have had transplants, who are on immunosuppression medications, if they're on immunosuppressants for other reason, any other genetic conditions that increase the risk of skin cancer, probably not going to be something that you need to worry about generally. But BCCs, basal cells, can occur in any skin type, and in women and in patients under 60, especially if tanning beds have been used. Again, the FDA did try to ban tanning beds for those under 18. We haven't been successful with that yet. Sorry, I'm bringing a little bit of advocacy here to my talk because I do enjoy it. But it is the more using a tanning bed one time increases your risk of melanoma by 60%. So patient education and warning signs of basal cell. So it's a new or open sore that won't heal after 6 weeks, a spot on the skin that bleeds easily. I often have patients who say, yeah, I just kind of like wiped a towel on my face after I got out of the shower and it just started bleeding. A reddish patch or a shiny area. I often do like a little movement of the skin in my exam, and if it looks like it's shining differently than the skin naturally shines, that's a worry sign for me. So a shiny bump or a nodule, a pink growth, a pimple-like growth, or a scar-like area. That's a different type of basal cell, but still something that would be new and different on your skin. All right, so now we have squamous cell carcinoma. This is the second most common type of skin cancer, still treatable, still curable, still unlikely to metastasize or get worse, still highly curable, but tiny bit more aggressive. So here are different types of that. Squamous cell, basal cells all pretty much look the same. Squamous cells can look really different. So like this one is like a red, scaly, pink patch. And then these are like scaly bumps, and they all look very different. This one might be a special type of squamous cell called a keratoacanthoma, and they tend to have like kind of like a little keratin horn, kind of firm horn in the middle. So they all look kind of different. So what are our clinical manifestations? What does that look like? What are we looking for? So either a patch, like that scaly patch, or a bump, or a nodule, pink or red, or skin color, or white. That classic non-healing sore, again, more than 6 weeks, you still have it there, it needs to be looked at. Some squamous cells actually arise very quickly, like those bumps, I think maybe on the chin and on the extremity. Those are the type of squamous cells that typically arise very quickly, like within a week or two. It's okay. We'll take them off. It's okay. They can scale, they can have callus thickening, they can feel very firm. They can present it as a cutaneous horn, as you see on that person's cheek. And like I said, they may bleed with minimal trauma, and they're usually asymptomatic. Most skin cancers you can't really notice, you can't really feel, they're not hurting you, they're not bothering you, they're very asymptomatic. Sometimes they could be, but sometimes they could be itchy and sometimes they could be sore, but usually not. Okay, that's my skin cancer portion, and I want to be cognizant of time because we're already at 1:51. So drugstores, do's and don'ts. So these are just my like go-tos. Like you should have these in your cabinet at home, and you could take these out of your cabinet if you have them at home. If I say a don't, maybe. Okay, so do's: hydrocortisone. Hydrocortisone 1% is like the best. It's hardly ever fungus. People always reach for an antifungal first, but they really just need a topical hydrocortisone. That's a great thing to have in your medicine cabinet. Oral antihistamines, great thing to try as opposed to Benadryl cream. Benadryl cream like doesn't do anything. And oral antihistamines, Benadryl for nighttime, although caution in older age groups, just because it can make you feel a little bit sleepy or dizzy. So you could take non-drowsy antihistamines like Zyrtec, Allegra, Claritin. There's a new one called Xyzal. They're all non-drowsy antihistamines, and that's your best way to get rid of itch. Another itch recommendation is Sarna lotion down here. Nizoral shampoo is the same ingredient that we use for our seborrheic dermatitis, cradle cap, dandruff shampoo, but it's a little bit lower percentage wise. Adapalene is an over-the-counter retinoid for fine lines and wrinkles. It used to be a prescription, and now it's not. And then Rogaine. Rogaine is great for male pattern or female pattern hair loss. It is over the counter. 5% is what I recommend for both men and women. And it's very safe, and it really does grow. It really helps you keep what you have, and it helps you grow a little bit. I would not recommend anything with salicylic acid or benzoyl peroxide wash. Benzoyl peroxide, because it's for acne, and this is geared toward older, so I don't think acne is so much of a problem. Again, I mentioned the Benadryl cream. Toenail fungus, like pretty much impossible to get rid of with over-the-counter remedies, so please don't waste your money on that. And Lamisil cream, I think, can be okay for maybe athlete's foot, but probably not for your toenail fungus. Old dog, new tricks. Eczema. Eczema we used to think of as a childhood disease where kiddos had very dry skin, and then as they get older, they grow out of it. It's now becoming more and more common in adults, and we have great treatments that are beyond topical creams. We have non-steroidal creams, so you don't have to worry about using a steroid, which is actually bad to use over a long period of time. And we have injectable medicines that actually treat the eczema from the inside, decrease your body's hypersensitivity reaction to allergens, because eczema is allergy of the skin. And so if it's something that you've dealt with for a long time, especially dry skin on the hands is the most common manifestation in adults, definitely see your provider. Psoriasis, again, this is an amazingly treatable disease now. It is a chronic, not curable inflammatory condition, but we have so many drugs for it now that make you feel like you're cured. And they're typically injections. There are a couple pills, and it's just life-changing because you feel like you don't have psoriasis anymore. And just as in terms of where, most people don't look like these pictures, but if you have psoriasis just in your scalp or just in your fingernails, this is actually a manifestation of psoriasis in the nails. Those people are at risk of getting joint pain. So it's actually important that we treat your psoriasis from the inside so that you don't get joint disease, you don't get joint pain, you don't get psoriatic arthritis, and we can protect you and your joints from the inside. So I just wanted to show those examples. I'm sorry that I have to go quickly at this point. Rosacea, that can definitely be treated. And so don't settle for your face looking like that if you want some treatment for rosacea. Hair loss, again, the most common is male pattern or female pattern baldness, which is a combination of androgens, which are testosterone, and genetics. So how the pattern was in your family. So androgenetic alopecia is hair loss, and Rogaine is a good one. Oral minoxidil, we give a lot now, and that's also a really good medication, helps you grow a lot more. And then there is alopecia areata, which is this special manifestation down at the bottom that has smooth patches of hair loss. And we have lots of ways of treating that as well now. And then finally, when to seek medical attention when you have a new or open sore that won't heal after 6 weeks, a spot that bleeds easily, these other signs that I talked about for skin cancer, a new mole after age 40. You do not get new moles. Now, remember, we saw a lot of things that could look like moles, but we don't get new moles, brown, round moles after age 40. So if you have something like that, definitely have someone look at it. Treating a skin condition for more than 6 weeks to 3 months that hasn't resolved, we can definitely do better than that. Please come back in and get it taken care of. Given a topical steroid that you use ongoing and the problem returns and you use a topical steroid, we definitely have different treatments and better treatments for that now. Okay, I'll leave it at that.
Thank you, Ms. Horwitz, for that very informative presentation. Unfortunately, we don't have that much time, so I apologize up front. We won't be able to get
I
to everyone's
apologize too.
questions, but I'm going to go through a few as many as we have time for. And if you could answer them as briefly and as succinctly as possible, please. So the first question is, how do you feel about micellar SP water?
Say it one more time. Oh, micellar water.
Right, micellar water. How do you feel
I
about
would
it?
say that the micellar water seems more like a toner to me, and so I would say it's not needed.
Okay. And when you talked about a gentle wash in the morning and moisturizer, were you referring to it being applied to the whole body or just the face or where? And also the
Sorry.
same for sunscreen. Where specifically
Yeah.
does it need to be applied?
Yeah, so mostly just the face because people are mostly concerned about anti-aging in the face. And another great place is top of the hands, not for necessarily the moisturizer, but for the sunscreen. So face for moisturizer and washing, sunscreen on face and back of the hands, unless you are exposed. Obviously, if you're wearing a short sleeve shirt or something like that, I want it on any sun exposed. Oh, actually, also the décolleté, the neck, the V of the neck is often missed as well. So for dry skin, moisturize all over the body. For that AM routine, I was just sort of talking about the face.
Do you recommend wipes to take off makeup before a wash?
That's fine.
Okay.
As long as yeah, it doesn't irritate your skin.
Do you have any recommendations on perfume-free daily skincare products? And then thoughts on Neutrogena fragrance-free soap?
Yeah, so Vanicream is a great line of super hypoallergenic, very clean ingredients. And so there's no dyes, there's no perfumes. Dove has a sensitive, it has no dyes, no perfumes. Um, what was the second part of that question?
Oh, I'm sorry. Let me scroll back up. Your
Uh,
thoughts on Neutrogena fragrance-free soap?
I didn't even know that Neutrogena had a fragrance-free soap. I guess I always say with Neutrogena, not the orange or yellow soap, because that means it has salicylic acid in it.
Okay. What do you recommend for upper lip wrinkles? And would the treatment show improvement in someone aged 70, 75?
Sure. So upper lip wrinkles can be treated with Botox, and it's pretty successful. And so, yeah, so even if it's been there for a long time, if you do several treatments, just like my newspaper analogy, it will eventually sort of settle out. And yeah, it definitely is worth trying in the 70s. It's still got a long way to go.
What are the possible negative side effects for Botox?
So the worrisome things are the Botox migrating outside of the site of where you injected it. So the recommendation is to not exercise the same day you have Botox and not to lie down for some like 4 to 6 hours after you've had Botox, and then that mitigates those risks. So by if you exercise, it's actually just metabolizing quickly. So that's just silly because you just spent $500 on your Botox and then you just like metabolized it away. And then lying down is to help it not migrate. So those are the big risks. You can get sort of a lid drop or a ptosis. And that, unfortunately, there's nothing dangerous about it. You just have to wait for it to wear off.
Ladies and gentlemen, this concludes today's webinar. On behalf of the Community Health and Wellness team at Suburban Hospital, we sincerely thank you for joining us and extend our deepest gratitude to Ms. Horwitz for sharing her expertise today. We hope this discussion helps you make more informed choices regarding your health. As a reminder, please take a few moments to complete the survey that will appear at the end of the webinar. Your feedback is greatly appreciated and helps us improve future programs. Thank you again and have a wonderful rest of your afternoon.
Bye. Thank you.